I think you heard me allude to where I want to see the field move, which is the use of CAR T-cell therapy in earlier lines, in particular the frontline setting. I didn't mention earlier when I talked about unmet needs, but one of the major unmet needs is how do we address the fact that therapy for ALL is 2.5+ years long? That is a lot of therapy, and it's a slog. Again, especially for adults, they don't tolerate the mercaptopurine and the methotrexate, even the vincristine, as well as our pediatric counterparts. They're trying to hold jobs, finish their education, do all of those fundamental, or participate in all those fundamental parts of life, while experiencing frequent cytopenias, LFT aberrations, elevated bilirubins, you name it, trying to carry them through that long maintenance course. And that says nothing, by the way, of the toxicities they may experience just trying to get them through that initial, induction, consolidation, interim maintenance, delayed intensification phase, right? Our true treatment phase. This says nothing of all the intrathecals. This says nothing of all of those. Again, they're tough. They're tough things to ask our adult patients to entertain. And when we try to sort of fast forward into the very elderly population, it gets even harder, right? How do you carry now, not a 20-year-old, but a 60-year-old or a 70-year-old through, each of these blocks of therapy? No, they don't have to worry as much about, career and family and education. But boy, the morbidity that they're going to carry from each of the things that we do is going to be higher because their reserve is lower, and their ability to bounce back from those therapies is going to be much less. And so this again is where I see the earlier implementation of our novel agents. I didn't mention it earlier, but I really like this mini-CVD Inotuzumab Blinatumomab concept, right? It allows us to come in with a lower dose of Inotuzumab. It allows us to consolidate with Blina. I would ask the question, now that we have the data from ZUMA-3 showing that those exposures to those agents don't impact CAR T-cell responsiveness, I would make an argument that maybe that is a wonderful frontline approach, right? Give your mini-CVD-NO, give your Blina. If you have MRD, or if you feel like this patient has high-risk disease and you're worried about their ability to tolerate transplant, or they're not, again, for all the reasons that transplant is difficult, what an optimal population now to begin thinking about CAR T-cell immunotherapy, right? Give 1 or 2 cycles of your mini-CVD-NO, give a cycle of Blina while you work to conduct your apheresis and your manufacturing of your CAR T-cell therapy, and then come in with your CAR. You've just shortened that therapeutic paradigm, right, from years to a period of a few months. That's powerful stuff. And, from my perspective, that's how I'd want to see CAR T-cell therapy evolve for this particular disease.